I hope my slides are visible, sir.
Yes, they are visible.
Yeah. So, good afternoon. Thank you for inviting me in this extravaganza. So, today I will discuss about the NGS-based liquid biopsy profiling that identifies the mechanism of resistance to ALK inhibitor, a step towards personalized NSCLC treatment. So, as you all know that ALK gene rearrangement in the lung cancer is the second most common targets we see. Usually, Indian patients, it's usually around 10% patient is having this ALK gene rearrangement, and this is the frontline management and the challenges associated with ALK positive NSCLC is that mostly crizotinib followed by alectinib and lorlatinib, and sometimes data is available. So current treatment options and unmet needs of ALK positive NSCLC is that most of that almost 40% of our ALK positive patients having CNS metastasis and that have poor prognosis, and there are different ALK resistance mechanisms are emerging, and basically continues to be a treatment challenge even in the availability of the second generation of ALK TKI. So lorlatinib is the third generation ALK TKI that developed to overcome the secondary ALK kinase domain mutations, and biomarkers testings basically need to repeat tumor biopsy upon disease progression may not be feasible, and liquid biopsy with cell-free DNA or NGS enables the liquid biopsies is a valid and significantly faster approach to detect different ALK resistance mechanism. So in this study, in the ALK cohort, patients eligibility more than 18 years, stage 4, advanced non-small cell lung cancer patients who are ALK translocation positive. Plasma samples were collected upon disease progression, which was assessed according to the RECIST criteria. And if you see that 26 plasma and 2 cerebrospinal fluid samples were collected from 24 advanced ALK positive NSCLC patients who have progressed on different ALK TKI. The mutations identified by NGS were confirmed by the digital PCR. So treatment naive patients who progressed on a first line crizotinib, that was total number of patients was 11, and who have progressed on alectinib, there are 2 patients. So median PFS was 11.6 months, and median overall survival was 24 months. And patients who progressed on a second or subsequent line, that is 12 number of patients on ALK TKI, the median PFS was 5.4 months, and median overall survival was 11.2 months. So NGS analysis upon disease progression, so plasma samples yielded higher cell-free DNA concentration than the CSF. So in total, 61 somatic variants of ctDNA from 24 samples were detected. Somatic mutations was detected in 14 genes. So most common was TP53, LPIK3CA, SMAD4, MAP2K1, FGFR, FGFR2, FGFR3, BRAF, EGFR, IDH, MYC, MET. So these are the common mutations detected. The average number of mutations per patient was 2.18, and median MAP was 0.39%. So specifically, a c-MYC gain in conjugation with CCND1 and FGFR3 loss was detected in a patient who progress was on the first line crizotinib. So co-mutation plot here, it has shown the co-mutation plot according to the ctDNA profiling of NGS, and each column usually represents the data of a single patient. The G120 mutations was identified in 4 patients who had progressed on alectinib and ceritinib. The S126Y mutations along with G120 mutations was detected in second line alectinib progressing patient, and G1269A mutations was detected upon crizotinib failure, and the L1196M mutations was identified after progression to crizotinib and lorlatinib. Finally, the A1200V mutations after crizotinib failure and the 1180L mutations was detected after first-line treatment with alectinib. So, somatic mutations was detected at the ALK locus upon treatment failure. So, these are the different mutations which are detected after progression on first line or second line LPKI. So, molecular mechanisms underlying the resistance to LPKI. So, EGFR exon 19 deletion, non-V600 BRAF mutations, and the F129L mutations in MAP2K, that is MEK1, were identified in 4 patients who showed no objective survival benefit to LPKIs. And potential LPKIs resistance mutations were also found in IDH2, PIK3CA, and MYC. And the oncogenic mutations of E545K, E545A in the PIK3CA gene were detected in the plasma sample of 2 patients who have progressed on ceritinib and brigatinib. So basically, solid tumor biopsies are the gold standard for biomarker testing. Whenever that repeat tumor biopsies are complicated and it's not feasible, so in that case, that liquid biopsy is a feasible option, and sequential strategies might have deleterious effects on the patient survival due to incompletely overlapping ALK mutations and that have coverage of different
Excuse me, sir.
LPKs.
Only
And
30
in this
seconds.
study, ctDNA profiling by NGS upon disease progression helps identifying different mutations at one point of time. And regarding different acquired mutations in the ALK locus, results are consistent with the different previous studies, and the data showed that the molecular mechanisms underlying the treatment failure seems to involve different pathways. So, NGS analysis of the liquid biopsies upon disease progression is a feasible and a valuable approach towards the approach that lead to the better care of the ALK positive NSCLC patient. In
Excuse me, sir.
NGS,
Sir, can you conclude, sir?
okay. So to conclude that NGS panel is a feasible and viable option to detect that different resistance mechanism, different resistance pathway, so that we can target the different pathways to overcome this ALK-TKI resistance. Thank you.